So as she does that, just wanted to give you a brief introduction of Dr. Periwasa. She has been on our faculty for a couple years now and completed her residency in internal medicine at Danbury Hospital, Yale New Haven School of Medicine. She went on to complete her fellowship in infectious disease at the University of Florida. She is currently an assistant professor of medicine at the University of Florida Division of Infectious Disease and Global Medicine, as well as a faculty member of the Southeastern AIDS Education and Training Center. Her research interest includes HIV, PrEP, and PEP, which you're going to hear a little bit about right now, as well as opportunistic infections in HIV patients. So without further ado, would love to introduce to you Dr. Periwasa. She's going to talk to us a little bit today about some new guidelines that have come out with HIV pre-exposure prophylaxis.
Thanks, Erin, for that introduction. Can you see my slides the way it's supposed to?
Yes.
Okay, great. Hey, hi everyone. Thank you for joining us today, and thanks, Erin, for that introduction. So like she said, I'm going to talk about pre-exposure prophylaxis, and I think a lot of things have come out in the new guidelines that I personally have not been doing the way they recommend. And I think there's a lot of new information in there that is very helpful. So I'm going to try and cover everything in 1 hour, which is a little hard because there's a lot of new information, but let's see how we do. So I have no financial disclosures. So the objectives of this talk, I want to talk about identifying patients at risk for acquiring HIV who may benefit from PrEP, describe the steps for prescribing PrEP, and then once you do prescribe PrEP, discuss how you should monitor them and what labs to follow up on, and then when you should consider stopping PrEP and how to go about stopping PrEP. So before we jump into PrEP, just a word about ending the HIV epidemic, this plan for America. This was brought up by the prior administration in 2018 with the goal of a 75% reduction in new HIV infections in 5 years and 90% reduction in 10 years. And they hope to do this. The DHHS focused on 4 main strategies to do this. And the first one being to diagnose all people with HIV as soon as possible. So we know diagnosis is really the key, and identifying these people is really the key. The next is to treat the infection rapidly and effectively. And here in Florida, I think we do a good job of this with our test and treat programs. The third is prevention of new HIV transmissions, and both by PrEP, so increasing PrEP uptake and increasing PrEP programs, and also by safe syringe programs. And the fourth of which is to respond quickly to HIV outbreaks and to get people the needed prevention and treatment services when these outbreaks do occur. The current administration has continued with this plan, but they have added on to highlighting priority populations and racial demographics, and highlighting the need, especially for PrEP uptake in these racial minorities. But both strategies highlight PrEP uptake as one of its main priorities. So what is PrEP, or pre-exposure prophylaxis? Basically, it's a HIV prevention method in which people who do not have HIV take a pill once a day to prevent acquiring HIV. So the most important thing about PrEP is that it's for people who do not have HIV. And it's important that we confirm that they're HIV negative, as this PrEP treatment regimen is not it's a prevention regimen and not a HIV treatment regimen. So if it is insufficient as a HIV treatment regimen. So you need to make sure that your patients are HIV negative prior to prescribing PrEP. So I think we have a polling question as the next one right here. So true or false, PrEP, if taken with high level of adherence, it can have an effectiveness of up to 99% against HIV acquisition to sexual transmission. So you guys can, it's a single choice, true or false. If you guys can pop that in the poll as we go forward, I think the answer is maybe already on the screen. Do you see result, guys? I can't see if anybody has resulted. Okay, so I'm going to say that, yeah, 100%, you got it. So it's true, because we, as you all know, and you guys can click out of the poll on your screen. As you all know, we have 50,000 new HIV infections every year in the US, okay? And we have no cure. 40 years into the HIV epidemic, we have not yet found HIV cure. We have no effective vaccine. So the main tool we have really is treatment for suppression and prevention of HIV acquisition. And if you look at the studies done on condom use, when you look at HIV prevention with condom use, even with consistent condom use, HIV acquisition there's only a 80% reduction in HIV acquisition among heterosexual couples, and it's about 70% for our MSM couples. And we know that when we talk to our patients every day in their life, there's very little consistent condom use reported by our patients. So we know that their risk of acquiring HIV is even less. But all of the PrEP studies have demonstrated with very high level of adherence to their PrEP medication, you can have 99% risk reduction in HIV acquisition. So those are really high numbers for any intervention in medicine. We almost never see 99%. So really, it's a very, very effective tool. And when you look at HIV transmission through IV drug use, it's about 74 to 84%, which is slightly less than your 99% with sexual transmission. However, even that number is really significant compared to all other interventions we have used. So really, this is a really effective tool in reducing HIV transmission, sexually and through other methods. So because of its high efficacy, in June of 2019, the US Prevention Services Task Force came out with this recommendation that any person at high risk for acquiring HIV should be prescribed PrEP. And this was a grade A recommendation from the USPSTF services. The CDC went further with this year, and they recommended that all sexually active adults and adolescents should receive information about PrEP. And if they ask for PrEP, that they should be prescribed PrEP. And they said, even if you have a discussion with your patient and you explain to them the benefit of PrEP, and even if they don't have clear-cut indications or risk for acquiring HIV, and they still continue to understand what PrEP is about and ask for PrEP, you should still go ahead and prescribe this. And they say when they looked at a lot of studies, our patients are not as forthcoming with their sexual risk factors with their provider as much as we would like, and they may have risk factors where they're not willing to talk to us about. So even if they don't have a clear risk factor that you can identify, if they continue to feel that PrEP is of benefit for them, you should go ahead and prescribe PrEP. And they further expanded on this, saying any licensed provider can prescribe PrEP. Like I said, as an infectious disease provider, I talk about PrEP, but PrEP is very easy to prescribe. Any primary care doctor can prescribe this in a primary care setting, and it does not need to be a specialized provider who's providing this medication. And they also CMS added on to this and recommended that all major insurances should provide coverage for PrEP medications and labs needed for PrEP. So what are the potential benefits of PrEP? Like I said, 99% effective for transmission of HIV, but it also answers a lot of the problems we have with relation to our discordant couples. So we know that when we have our HIV positive patients, even though they're virally suppressed or may or may not be virally suppressed, they worry about being sexually active with their partners. There's a lot of anxiety associated among discordant couples. They worry about trust, sexual pressure, intimacy, and the PrEP really solves a lot of that problem. And I think as providers, PrEP gives us an opportunity to talk about sexual health and to do STD testing, to do HIV testing, and to help our patients be more proactive about their sexual health. So not only preventing HIV, but really be proactive about sexual health from a provider standpoint and a patient standpoint. Having said that PrEP is great, really efficacious, unfortunately, a lot of people who would benefit from PrEP are currently not on PrEP. And as you see here on this graph, you see all the different risk groups for people who have indications for acquiring HIV. And you see the percentages of people among that group who are currently on PrEP. So among MSMs, only 24% are on PrEP. Among people who inject drugs, only 18.5% are on PrEP, and heterosexual 0.4. And overall, when you look at the total number, the CDC estimates there's about 1,200,000 people here in the US who would currently benefit from being on PrEP and have risk factors for acquiring HIV. However, when you look at the 2018 data, the number of people who are currently on PrEP in the US is about 100,000. So from 1,200,000, only 100,000 are on PrEP. So really we have ways to go in increasing PrEP uptake in our community. And that should be really one of our goals to achieve. And another thing I want to highlight when we talk about PrEP uptake is that there's a lot of socio-demographic and racial minorities who have less access to PrEP and who have lower numbers of PrEP. So PrEP uptake among racial minorities is not equal. So if you look at this graph here, 44% of people who could benefit from PrEP are actually African American. And among the African American population, only 1% is currently on PrEP. So disproportionately, the number of people on PrEP is less among African Americans. And the same can be said about our Latino community. Among the population who could benefit from PrEP, 25% are Latino, and among them only 3% are currently on PrEP. So really increasing the opportunity to provide PrEP for this population, and also increasing education about the PrEP and its benefits in these populations is really important. So what are the current options available to us for PrEP? So there are a couple of oral medications that have been around that all of you are familiar with. We know that there's two main oral pills. One is emtricitabine combined with tenofovir disoproxil fumarate or Truvada, and the other is emtricitabine tenofovir alafenamide combination, which is we refer to as Descovy. And these are both one pill once a day formulations. And as of December of 2021, they have now approved the intramuscular preparation for PrEP, which is called cabotegravir. I think the brand name is Apretude, and this is a 600 milligram IM injection that's injected into the gluteal muscle, and this can be given every 2 months for our PrEP patients. So we'll talk a little bit about both these PrEP formulations, and all of these formulations are approved for adults and adolescents as long as they weigh above 77 pounds. When starting a patient on PrEP, it's important to remember that PrEP is not just about prescribing a medication and then monitoring that medication. It should be part of a comprehensive HIV prevention package. And like I said, it really gives us the opportunity to talk to our patients about their sexual health. So you can talk to them about consistent condom use because you're still worried about STI transmission. You can counsel them about appropriate testing for STDs and treatment for STDs as needed. And it also gives us an opportunity to do it frequent HIV testing, which as I highlighted in the previous slide, is really early diagnosis of HIV is really key. So PrEP should be done as part of a full package that includes safe sex counseling, STI testing and treatment, and HIV testing, and for our female patients, pregnancy testing as well. So when we talk about PrEP, it's the first step when trying to assess a patient if they need PrEP or not. The first thing we have to do is take a good sexual history. And I think as providers, we need to really become comfortable with taking a good sexual history. We need to have like honest, open discussion with our patient and create an environment where patients don't feel judged and are able to open up to us and have a free conversation with us, because if we are not able to identify their risk factors, we won't be able to see if they are a candidate for PrEP or not. Sorry, excuse me. So when I talk about taking a sexual history, I think the best way to remember how to take it is the 5 Ps. So this is what I teach my residents and medical students. It helps me not forget parts of history that I would like to obtain. The first P is for partners. So you want to know if they're with a single partner, multiple partners, whether their partners are female, male, or both, what their sexual practices are. So whether they engage in oral sex only, whether they engage in oral, vaginal, anal, insertive sex or not. What sort of protection they take from STDs. So whether they use condoms, and if they do use condoms, whether they consistently use condoms, and if they've recently been treated for STD or had symptoms of STD, sorry about that, recently had symptoms of STD or not, and if so, should they be tested? And for our female patients, again, you want to ask them about what are the methods they're using for prevention of pregnancy, or if they're anticipating a pregnancy or not. So going forward, talking about PrEP steps, the first thing is to identify indications for PrEP. So first of all, you get a good sexual history and you see if they have any indications for PrEP. The next step is assess their risk for HIV acquisition. Then you go on to laboratory evaluation, prescribing PrEP, and then clinical follow-up and monitoring. And let's go by these steps one by one. But I think we have a polling question next. Here, if you can help me with that. Yep, here it is. So I'm going to read it out. Which of the following patients could benefit from a conversation about the opportunity to initiate PrEP? A male patient who is in a monogamous relationship with a HIV positive sexual partner, a female patient presenting for treatment of primary syphilis, a male patient who discloses that he is a commercial sex worker, a female patient who is followed for injection drug use issues and relays a recent history of sharing injection equipment, or all of the above. So I'll give you about 10 seconds to go ahead and think about that and put in your answers. And I think, let's see what people have to say. Yeah, so yes, all of the above. So all of these patients should be considered for PrEP. And I'm going to go ahead and close that poll and go on to the next slide. And you guys can do the same if it's still on your screen. So who should be offered PrEP? So the CDC kind of simplified this year with their newer guidelines. And they said any sexually active adult or adolescent who's had anal or vaginal sex in the past 6 months and have one of the following risk factors. So if they have a HIV positive sexual partner, if they have a bacterial STD in the past 6 months, or they have a history of inconsistent or no condom use with their sexual partners, any of these patients should be considered for PrEP, and you should have a more in detail conversation with them about their sexual risk factors and see if they would be a candidate for PrEP. In addition to that, in our people who inject drugs, who we see either for substance use disorders or for prescribing Suboxone, if they have a HIV positive injection partner, or even if they share injection equipment, they should be considered for PrEP. So really, it's much more simplified now, and we should consider all these people to have a discussion about PrEP. So once we have identified risk factors for acquiring HIV, and we think they might be a good candidate for PrEP, we need to make sure that they do not have acute or chronic HIV. So like I said, PrEP does not treat HIV, it only prevents HIV. So it's for people without HIV. So how do we go about screening for this? Like I said, our tests are only good for chronic HIV infections. So we have to look for signs for acute HIV, and we'll talk about that in the coming slide. But you should also document a negative HIV test, ideally within a week of starting PrEP. And this test, if it is a rapid test, it should be a rapid blood test and should be confirmed by a confirmatory 4th generation test. You should not use oral fluid rapid tests for ruling out HIV, and you should not use patient-reported test results or anonymous test results. You should have access to the lab report itself. So how do you rule out acute HIV? So acute HIV is a very vague can be a very vague presentation. And some of our patients note a flu-like illness, some mild changes that they may have. But when you see your patient, if they have fevers, night sweats, if they complain about some lymph node swelling or oral thrush, if they have mouth ulcers or they're just feeling weak and tired, that should give you a red flag that maybe this person has acute HIV. And in that case, you might want to do specialized testing like doing HIV RNA and hold off on starting PrEP. The other thing we need to know is if they had a high risk exposure within 4 weeks of starting PrEP. So if they had a sexual encounter without a condom with the HIV positive individual, or if they shared their injection equipment with the HIV positive individual within the last 4 weeks, we know they're at risk for acute HIV. And if you have a suspicion of a high risk encounter in the prior 4 weeks, you should hold off on starting PrEP and retest the patient. And we talk about why our current tests are not good at grasping that acute HIV infection phase. So currently we are using the 4th generation antigen antibody test. And prior to that, we used the 1st generation and the 2nd generation HIV antigen antibody test. And those were IgG tests, and they took a while to become positive. They took up to 50 days to have a positive result. Our current test, after that, we had the 3rd generation test, which included both IgG antibodies and IgM antibodies, and they were faster a little bit sooner than our prior test. And currently, we have our 4th generation antigen antibody test, which has a P24 antigen in addition to the IgG and IgM antibodies. And this becomes positive pretty soon after HIV exposure. But if you look at it, it takes about 15 to 20 days for that 4th generation test to be positive. So you still have that window period where you may miss an acute HIV infection. So that's why I talk about if there's a concern, there's a high risk exposure in the prior days, you're worried about that. And you can narrow that window further by doing an HIV RNA test, which can be positive in 10 to 15 days of acute HIV exposure. But again, there's still a small window period where you may miss acute HIV. So again, if you have any suspicion for acute HIV, you can hold off on starting PrEP and repeat the testing. So here we look at the algorithm for the HIV antigen antibody test. So for most of us, we'll do a 4th generation test. If you do a rapid test, you want to confirm it with the 4th generation antigen antibody test. And if it's negative and the patient has no symptoms of acute HIV and has not had a high risk exposure in the last 4 weeks, you can think that they're HIV negative and go ahead and start your PrEP. If it's positive, you have a new HIV diagnosis and you do not want to start PrEP, you want to start them on HIV treatment regimen. But the problem is if they have an indeterminate test. So when that happens, it will reflect to a HIV RNA test. So most of the tests are set up so that it reflects us automatically. If your lab does not reflect it automatically, you should request a HIV RNA test. And this is where it gets slightly complicated. If the HIV RNA is negative, you can rule out HIV and start PrEP. If it's positive with a HIV RNA count of more than 200, then you have a HIV positive patient, again, just like here. So it's a new HIV diagnosis and you want to not start PrEP and start on an HIV treatment regimen. But here is where we run in. Here, when you have where it's detectable, but it's less than 200, is where you run into issues, because the problem with the HIV RNA test, even though we depend on them a lot, they can have false positivity. So in that case, if it's less than 200 but detectable, you want to redo your test and hold off on starting PrEP. And now we have had multiple studies where you can have a HIV RNA that can be false positive even up to 3,000. So it's something to keep in the back of your mind that HIV RNA tests can have false positives. And you might want to reach out to a HIV specialist if you have discordant results. So that is when you are starting patients on PrEP. So let's talk about testing when people are on PrEP. So when people are on oral PrEP or the intramuscular PrEP, we do routine HIV testing to make sure that they're staying HIV negative. But this testing may be unreliable in people who are on PrEP because the antiretrovirals used in PrEP, it can suppress early viral replication. And that can affect your testing and prevent development of antibodies. And your test may be negative, but it may be a false negative. And when we looked at the studies done on cabotegravir, which is the intramuscular PrEP, in the HPTN trial, the antigen antibody test was negative. And when they went back and tested the blood, they found that it was positive when they did a HIV RNA. Let me say that again. So in the HPTN trial, while they were on cabotegravir, they detected a positive antigen antibody test. And when they went back and looked at prior blood and retested that blood, they realized that they missed the acute HIV infection by 62 days when they retested with HIV RNA. So they missed baseline HIV infections by 98 days. So we know that just doing the HIV antigen antibody test may not be sufficient, and you might need to do a HIV RNA as well, so as not to miss these infections in people who are on antiretrovirals. And they found that this is similar, but not as extensive for even oral PrEP. So even in people who are on Truvada, their HIV antigen antibody tests continue to be negative despite having HIV for 34 days. It was missed by 34 days in these test trials. So given that all of us, we have traditionally been doing antigen antibody tests while people are on PrEP before we refill their prescription. But now with this new data, we can't do what we have been doing. So now the CDC recommends this new strategy of doing both the HIV antigen test and the RNA while people are on PrEP. So if anybody has been on oral PrEP or for the last 3 months or on long-acting cabotegravir over a year, you should do both the HIV antigen antibody and an RNA test to rule out HIV before refilling their prescription. And if both are positive, you have your answer. This is a new HIV positive patient, and you need to stop PrEP and start them on HIV treatment regimen. And if both are negative, they're HIV negative, so you can continue your PrEP. And if you have discordant results, this is when you can either decide to continue or stop your PrEP or add a third medication till you get a repeat blood test. But while you're waiting for you should repeat both tests again. And while you're waiting for that repeat test, you can consult with the HIV specialist or the National Clinicians Consultation Center to figure out if you want to continue the PrEP or add another agent to make it a 3-drug regimen to treat HIV if they do have HIV. So this is where it gets a little bit more complicated, but it's important to do both tests. So in summary, I just want to highlight this because this is something new in the new guidelines. For patients who are starting PrEP, you do a HIV antigen antibody test alone. For people on PrEP, before you do their next refill, whether it's oral PrEP or with cabotegravir, before you do their next injection, you want to do both the HIV antigen antibody test and a HIV RNA to rule out HIV. I hope that is clear. And so let's talk a little bit about oral PrEP options. Like I said, we have both Truvada and Descovy. These are one pill once a day that you can take. Truvada is approved in 2012, and it's approved for everybody who's at risk of acquiring HIV, whether it's through sex or injection drug use. And it can be used up to an eGFR of 60. For Descovy, it's a little different, and you have to remember this. It's only approved for people at risk of acquiring HIV through sexual transmission. But it excludes people who are at risk through receptive vaginal sex. So if you have a patient who is assigned female sex at birth and they have vaginal receptive sex, they cannot be prescribed Descovy and have to be prescribed Truvada for PrEP. And that Descovy can be used at a lower renal function, so it can be used up to an eGFR of 30. So Truvada, like I said, it was approved in 2012. It's one pill once a day, and the potential side effects are very limited. You can have some headache, abdominal pain, weight loss, but this is what we refer to as startup syndrome, because these symptoms usually resolve in 2 to 4 weeks. So I usually advise my patients, you may get these symptoms, but they will resolve. So don't stop your medication. You can just take symptomatic medication, and after a while, these symptoms should go away. There is a potential for decreased bone mineral density. We see this in our patients who have HIV, but this risk is significantly low and has not been shown to be clinically important in our patients on Truvada for PrEP. There's really no increased fracture risk, and the changes in bone mineral density are reversible, and it's less than 1%. So not really clinically significant. The same can be said for renal dysfunction. Again, for our tenofovir patients who, for HIV-infected patients on tenofovir, we worry about this more, but the studies done in PrEP have not shown a significant renal dysfunction while on PrEP. Descovy, like I said, unlike Truvada, it's only for people at risk through sexual transmission, excluding people at risk through receptive vaginal sex. This was approved in 2019. It's one pill once a day by mouth. Again, it has similar startup syndrome side effects with headache, diarrhea, and abdominal pain, but these symptoms usually resolve within 2 to 4 weeks. And you can have bone mineral density reduction and renal dysfunction. Again, this is reversible and very mild. And with Descovy, those side effects are even less than with Truvada. So in summary, both Truvada and Descovy is approved for prevention of HIV. Truvada is approved for HIV prevention through sexual transmission and IV drug use, through IV drug use as well. Descovy is only approved for prevention of HIV through sexual transmission, excluding people who are at risk through receptive vaginal sex. Truvada is approved for a renal function up to eGFR of 60. Descovy can be used up to eGFR of 30, so slightly less renal dysfunction. And they both are very well tolerated. Descovy has slightly less bone mineral density and renal side effects compared to Truvada. Descovy does have the potential to increase weight gain with its TAF component and also hyperlipidemia. So that's something we take into account when we prescribe Descovy for PrEP. And more importantly, Truvada is now generic. So for our patients with payment issues, this may be a better option. Sorry. So who is eligible? So how can our patients become eligible for oral PrEP? They should have a negative HIV test. Like I said, that is key. They should not have any symptoms of acute HIV infection. They should have a normal renal function, and they should not be on any contraindicated medications. So when we think about starting our patients on PrEP, we do our HIV test. It's really important to do STD screening. Like I said, PrEP is part of a comprehensive package. So you want to do your gonorrhea and chlamydia testing. And this is where your sexual history is important, because you want to test at all sites of exposure. So if your patient is having oral or anal sex, in addition to getting a urine NAT for gonorrhea and chlamydia, you should also do oral swabs and anal swabs to test at the site of exposure. You should also have syphilis testing for all your patients. You should get baseline serology for hepatitis B and C. You should check their renal function. And if they are going to be started on Descovy, then you need to do a baseline lipid panel. And in our female patients, you want to get a pregnancy test for women. So why is hepatitis B serology important? So if your patient has chronic Hep B, this is not a contraindication to starting PrEP, as both Truvada and Descovy will treat Hep B. It is important to know whether they have chronic Hep B, because while they're on PrEP and they're on a treatment regimen for Hep B, and if they stop their PrEP medication suddenly, they're at risk for having a hepatitis flare and going into liver failure, which can even be fatal. So we need to know their Hep B status prior to starting PrEP. And while they're on PrEP, we need to advise them, if they ever stop PrEP, they need to be monitored closely for a hepatitis flare and maybe be managed with a hepatologist as well. A couple of medications you want to think about if your patient is on, may interact with TAF. I haven't gone into a detailed description. You can refer to the guidelines, but some of them, the Hep C medications, can increase the TDF levels in the blood. And then St. John's wort, we know a lot of our patients may take over-the-counter medications. So it's important that we know if they're taking any over-the-counter St. John's wort, and it cannot be co-administered with TAF. The other important medication to think about is the rifamycin. So these are medications we use for either active TB or latent TB, and rifampin, rifabutine, rifapentin, they can be used with Truvada, so your TDF medications, but they cannot be co-administered with TAF. So for Descovy, they cannot be co-administered with rifamycins. Prescribing and monitoring. So you do your base, you figure out your patient is at risk for acquiring HIV, you rule out acute HIV, you do your baseline labs, and now you're going to prescribe your PrEP. So you always, the medications are 1 pill once a day. They can be taken with or without food, and you only give 90-day supply. So you don't want to give more than 90 days because you want your patients to come back and be retested before you give a refill on their medication. And one of the important things you want to tell your patients when you start them on these medications is when Truvada is started, takes about 20 days to have protective levels in the cervicovaginal tissues, and 7 days to reach protective levels in the blood and rectal tissue. So they need to know this, as they need to use other prevention methods during this period until they have drug levels sufficient to be protective against acquiring HIV. The current data for TAF is not available, but we assume that it's along the lines of our TDF. And this is one of the key things about PrEP is adherence. I can't say it enough. So if you look at this graph, I talk about the 99% efficacy of PrEP if against acquiring HIV. But this 99% efficacy is based on good adherence and taking the pill once a day. And some of the studies have shown that if you take it twice a week for men, you will have enough protective levels in the colorectal tissue for about 70 to 80% efficacy. But in women, this is significantly lower because estrogen can reduce Truvada levels. So in men, it may be a little forgiving if you only take twice a day, but in our women, you really need to take 6 to 7 doses a week for it to be protective. So there's less protectiveness for our female patients. But really in all our patients, adherence is very, very key. And you need to take the time to talk to your patients about adherence. You want to make it seem non-judgmental, that they're open with you when they miss a pill. Usually I ask them, I don't ask them, did you miss a pill? I ask them, how many pills did you miss in the last month or so? So they're much more forthcoming with the history. And if they are missing pills, take the time to sit down and figure out what's making them miss the pill, figure out a way that they can include it into their a schedule that slides into their current social situation and social schedule. And if they have, you can set up reminder systems for them, or figure out at what time it's best for them to take it so that they don't forget to take it. So once you start prescribing, what labs do you need to do on a routine basis? So like I said, we are no longer doing just the HIV antigen antibody test. We are combining it with the antigen antibody and HIV RNA, and that should be done every 3 months. And then if your patient is above 50 years and they have their creatinine clearance at their baseline renal function test is less than 90, you want to test their renal function every 6 months. But if not, you can do it even every 12 months. So if it's a young patient less than 50 and they have a good baseline renal function and 90 when you start PrEP, you can only test it every 12 months. And then you want to always do your STI testing. You want to do it every 3 months with syphilis and gonorrhea chlamydia testing, again, testing at the site of exposure. And then you can do it every 6 months for a heterosexual and other population. But this should be done on a case-by-case basis because we know in our MSM and transgender, they are at higher risk for acquiring bacterial STIs. But even among our heterosexual population, if you think a patient is at high risk for acquiring STIs, you might want to consider every 3 month testing as opposed to every 6 months testing. And then for our patients on Descovy, they should have a lipid panel done once a year. In addition to that, for our female patients, you should do pregnancy testing as well. So that is about oral PrEP. I'm going to spend a few minutes about long-acting intramuscular PrEP. Like I said, this was approved in December of 2021. It's not yet commercially available, but it should be in the coming few weeks to months, I think. This is 600 milligrams of cabotegravir, which is an integrase inhibitor, and it is injected into the gluteal muscle every 2 months to prevent PrEP acquisition in people at risk. In the study, they did an oral lead-in and then went to the intramuscular injections, but this cannot be administered at home. So it's not being tested to be given given at home. So patients do need to come in every 2 months for a clinic visit. And it has to be given in the gluteal muscle. It's not being studied in other areas of injection. And this is really, I think a lot of patients I talk to are very interested in this. So I think that you see that interest go up. And it's an interesting option for people with renal disease who cannot take their daily oral pills, but they're willing to come into clinic to get this shot every 2 months. So a few words about the trial where this was approved. I think in the trial, in the HPTN 083 trial, they looked at MSM and transgender population, and the 084, they looked at sexually active cisgender women. And they both had an oral lead-in with a placebo or treatment. And then they went off into one team got cabotegravir long-acting every 2 months with an oral placebo, and the other team got Truvada and a placebo intramuscular injection. So they compared long-acting cabotegravir against oral Truvada, and they followed these people over a duration of 1.5 years. And if you look at the outcome, it was really found the long-acting cabotegravir was actually superior to the Truvada in both the 083 and 084. And if you look at people who acquired HIV, you had 13 infections in the cabotegravir arm compared to 39 new infections in the Truvada arm. And in the 084, which looked at women, and like I said, we know that oral PrEP in women, really you have to have high adherence, and it's less forgiving for women missing pills. Cabotegravir, you had 3 infections in the cabotegravir arm and 36 infections in the oral PrEP arm. So really, especially for women and overall, I think this is a really attractive option for our patients. So how do you initiate cabotegravir? Just like in oral PrEP, you want to have your negative HIV antigen antibody, and you should not have any concern for acute HIV. But you do your STD screening, again, gonorrhea and chlamydia at all mucosal sites, and syphilis testing. But you do not need a creatinine clearance, hepatitis B serology, lipid panels, or liver function tests. And another thing that they highlighted, even though the study used the oral lead-in, they felt that there were no side effects in that arm. So they felt that you do not need to do an oral lead-in when you do this for your patients. So it's no longer recommended. It does interact with some medications, just like with TAF. The rifamycins cannot be co-administered with cabotegravir. Rifabutin may be administered, but with caution. So for our patients on receiving treatment for active TB or latent TB, that is a concern. And then your anti-seizure medications like carbamazepine, oxcarbazepine, phenytoin, phenobarbital cannot be co-administered with cabotegravir, as they can reduce the exposure to protective levels of cabotegravir. So how is this given? Like I said, it's 600 milligrams IM, so it comes through about 3 ml suspension, and you give the first dose, you give the second dose within 4 weeks, and then you go to your 8-week intervals for IM injections. And the patients have to come into clinic to get this IM injection. The main side effect that they saw was injection site reactions. So in clinical trials, the injection site reactions were frequent, but they were usually only with the second and third injections, and after that, they seemed to go away. And these reactions were transient. They were just treated with warm compressors and over-the-counter Advil and NSAIDs. So really not that significant, but you should let your patient know that that's a possibility. And unlike like oral PrEP, you are going to do your antigen antibody test along with the HIV RNA. So we talked about not doing both those tests. And because of the dosing schedule, you're going to do them every 2 months as opposed to every 3 months, because that's when your patient is going to come in for their next injection of cabotegravir. You want to do your STD testing every 4 months for your high-risk patients with among MSM and transgender, and along with syphilis and gonorrhea testing. And you can do every 6 months for people who are not at high risk. But other than that, you do not need to do any other testing like renal function, hepatitis B serology, lipid panels, and so forth. So fairly simple to do. Having said that, so I think this is a really attractive option for all our patients, but there's a lot of logistics involved with this. So compared to generic Truvada, they haven't really set a price point for this, but it is going to be expensive. And then there's a lot of logistics involved with getting this medication to the clinics, making sure there's a nurse or a clinical provider who is able to give this IM injection. You need to have reminder systems to make sure that the patients are scheduled in time for their every 2 months to come in for the injection. And currently, they're not provided by all commercial pharmacies. So they're only provided by specialized pharmacies. So there's quite a bit of logistics involved in getting this up and running. And I think that should be considered, even though it has very high efficacy and seems to be very attractive for most of our patients. So those are your options for PrEP. And so oral PrEP, long-acting PrEP, the patient is going to be monitored. You continue to prescribe this. So what happens if your HIV test is positive? So if you're doing a rapid test in your office, you want to confirm it with the 4th generation antigen antibody test. And if it is truly HIV positive, then they can no longer be on a PrEP regimen. So you want to stop their PrEP regimen and then start them on a HIV treatment regimen. And you can reach out to a HIV specialist to do this. You can order baseline HIV testing like HIV RNA PCR, a genotype, CD4 counts. And then this is when adherence is really important. If mostly our patients on PrEP become HIV positive, even though it's rarely that it happens because of non-adherence. So especially when they're HIV positive now, adherence still remains very critical. And you want to ask them about their recent sexual partners. You want to let them know that now that they're HIV positive, the condom use is really essential. And you can offer HIV testing for their sexual partners. And if they had a recent sexual encounter, their partners may be candidates for post-exposure prophylaxis. But most importantly, you want to take a minute to talk to them about the diagnosis, reassure them, let them know that even though they're HIV positive, that this is no longer a death sentence. We have good HIV meds. Ask them if they need a family member to be contacted for support, and just kind of really support them during what is a difficult time when they know that they're HIV positive. So a few words about getting discordant HIV test results. So this is when you're monitoring your patient either on oral PrEP or long-acting cabotegravir, and you're doing both the HIV antigen antibody test and an RNA. So not what we were traditionally doing, but now we're going to be doing both. And you get discordant results. So whether you have a positive antigen antibody with a negative RNA or a negative HIV antigen antibody with a positive HIV RNA. In this setting, we know that we can have false negatives or false positives with both. So you want to make sure you repeat both tests. And while you're waiting for the repeat test, you can consider continuing the same oral PrEP regimen, or you can consider adding a third agent so that they have HIV treatment regimen. And you can decide this with consultation with the HIV specialist, or you can call the National Clinician Consultation Line before you make a decision and while you wait for the repeat testing to be done. So there is a risk of developing resistance with oral PrEP. If you acquire HIV while on oral PrEP, the risk is low. So the IPREX study, which was one of the main studies where they studied efficacy of PrEP, 48 people developed HIV while on PrEP, and they had no significant resistance noted in that study. And the partner study, we had 63 people develop HIV while on PrEP, and only 5 of them had any resistance noted, and it was very low level resistance with M184V. So it can happen, but it's very low risk. The risk is still there with cabotegravir. In the cabotegravir, we know is an integrase inhibitor. So if we develop integrase resistance, this is really concerning for us because integrase inhibitors are really kind of our backbone of our HIV treatment regimens now. And in the 083 trial, in the base, they had 4 baseline infections. And then they had 5 HIV infections in patients who had no recent cabotegravir exposure. So these are patients who stopped their IM cabotegravir, and they did note some integrase resistance in that arm. And there was 3 while taking the oral lead-in and 4 while they were taking appropriately timed cabotegravir. So this is still a concern for us, and we'll have to see as we start using this more and more, we'll have to see what these numbers do. One of the things we worry about, like I said, is missing a HIV diagnosis while people are on oral PrEP or even more so with cabotegravir. So if you can look here, this is data from the HPTN 084 trial. And if you see here, one of the patients had HIV at baseline, but this went undetected up to week 30 because they were testing with the HIV antigen antibody. And he was on cabotegravir, and he received the oral cabotegravir lead-in and then the IM cabotegravir. And he became HIV positive. But when they went back and retested his blood, he actually had a positive HIV RNA on admission that went undetected for up to 30 weeks. And we worry about this because we worry about potential risk of developing resistance. So again, we have to do the HIV RNA and the antigen antibody test while people are on cabotegravir. and there is a potential risk for acquiring integrase resistance if they do acquire HIV while on long-acting cabotegravir. So that is how you prescribe PrEP, monitor PrEP. So what if you want to stop PrEP on your patients? Why would you consider stopping PrEP? Again, if they have a positive HIV result or they have acute HIV, you're going to stop their PrEP regimen and start them on a treatment regimen. But there are other reasons where you may consider stopping PrEP. If they're non-adherent and they don't do their routine labs, they don't show up for clinic, then you may consider stopping PrEP. If they have some renal dysfunction or on medications that may interact, you may stop PrEP. It is important when you stop PrEP to document their HIV status at the time of discontinuation and the reason for discontinuation of PrEP. You want to advise them the risk of developing drug-resistant PrEP. This is more so with cabotegravir. So we know that cabotegravir, when it's given IM, it has a long, what we call a tail effect. That is, the levels stay positive, the plasma levels stay in your body. From the trials, we saw detectable plasma levels up to 44 weeks in men, and in women up to 67 weeks. So really a long tail effect. And if they acquire HIV during that time period, they may develop resistant HIV because they had that low level exposure to cabotegravir. So if they are on cabotegravir and they stop it, you want to tell them about this tail effect, this risk, and let them know that they need to use a highly effective HIV prevention method, whether it's to consistently use condoms or whether they want to be on oral PrEP until we think that the cabotegravir levels are low enough that they're not at risk. The cabotegravir levels are undetectable. The other important thing when people are on PrEP, it is always important at least once a year to have a discussion if PrEP is still a reasonable option for them, because our patients' social situations may change. They may have multiple partners and then be in a monogamous relationship with a single partner and no longer have risk for HIV acquisition. They may have had a period where they were injecting intravenous drugs and now have gone through rehabilitation and are clean and may no longer be at risk for acquiring HIV. So it's important to address whether PrEP is still needed and to see if their social situations have changed, and if they have changed, that you can stop PrEP in these patients if they're no longer at risk. So it should be thought about at least once a year and readdressed. A few words about PrEP in pregnancy. So Truvada PrEP is considered generally safe for pregnancy because we have been using this for many, many years in our HIV-infected patients and has not noted any adverse pregnancy outcomes. So currently the FDA says you can use PrEP off-label in patients who are pregnant. Our data from our HIV-infected individuals shows that it's safe, but you want to have an open discussion with your female patients if they plan on having a pregnancy or do become pregnant while on PrEP, and you can consider continuing it after having an open discussion with them and make a joint decision. A few words about on-demand PrEP, because I'm sure most of you guys have heard about this. This came out in the IPREX trial where they looked at among MSM population, they looked at people taking PrEP only on demand. So this is when the people in the trial, if they anticipated a high-risk sexual encounter, they would take a dose of PrEP 24 hours before the encounter, another dose 24 hours after the first dose, and then a second dose 48 hours after the first dose. And they would continue it until 48 hours after their last sexual encounter. And they found that there was an 86% reduction in HIV infections in this MSM population that they studied. But Currently, this is recommended by the International Antivirus Society of USA, but it is not FDA recommended. And one of the things that you note when you look at this study is the participants in this study were having multiple high-risk encounters. So overall, they were taking they were taking the PrEP several times, and they had overall high levels of Truvada in them. And this may not be as replicable if people who are not having as multiple encounters as the participants were in this study. And it was actually redone here in the USA, where they showed that when it was done in USA, it was the ADAPT trial, and the efficacy was about 68 to 65%, so slightly lower. So I think that if we do consider this, I think it should be done on a case-by-case basis. It's only studied in the MSM population and only studied for Truvada, not Descovy. And I think we need a little bit more information before we go ahead and do this for our patients. Because I'm short on time, I'm just going to run ahead to my last slide. I just want to say a few words about U equals U. I know this is old data. The partner study was in 2012. This was done among 888 couples. There were 548 heterosexual couples, 340 MSM couples. And this is when, if you are undetectable, your risk of transmission to a HIV negative individual was determined to be almost equal to 0. And this was based on this study where they had an HIV positive individual who was virally suppressed and an HIV negative individual who was not on PrEP. And they had 58,000 acts of condomless sex, and there was no transmission over 1.3 years. And this was further studied in the Partners 2 trial, which looked at MSM couples, and it was 927 MSM couples, again, discordant couples with 74,000 acts of condomless sex with 0 transmission. And I think this is important for our PrEP patients to know. If they are in a monogamous relationship with the HIV positive individual, and that individual is virally suppressed, their risk of transmission is 0. If they continue to feel that they would benefit from PrEP, I'm happy to prescribe PrEP, because a lot of our patients want to have control over their sexual health and not be dependent on their partner being virally suppressed. But I think when you have this discussion in these serodiscordant couples, you should talk to them about this data before you make the decision to continue PrEP or not. So I'm going to go ahead and end. And in conclusion, I want to say that PrEP works. It's easy to monitor. It has minimal side effects, and really, we can do it with very little lab work and very little testing, and it has very, very high efficaciousness. So we want to really increase PrEP uptake among our providers as well as our patients to provide this to more people in our community. And I am going to end there, and I will take any questions that people have. And I will put my email in the chat box as well, in case anybody has questions, because I think the new guidelines have a lot of information that is new to all of us. So I think it'll be helpful. I think a lot of questions might come up with as you go forward. Thank you.